Pain psychologist Dr. Beth Darnall joins me today to help you tap into the power of the brain to help reduce pain. We'll also take a look at a new danger uncovered about tattoos and a study that unveils one food that can help people lose weight. I'm Bob Garvin. Welcome to Body Talk, episode 105. If you have any questions or comments about this podcast, send an email to lifestarmedia@gmail.com or visit us on Facebook at Body Talk Bob Garvin. Tattoos carry a hidden danger. Scientists have discovered that micro and nanoparticles from tattoos travel inside the body and reach the lymph nodes. Researchers say that these pigments from tattoos, they travel to the lymph nodes, which then become tinted with the color of the tattoo. That study was published in the journal Scientific Reports. If you want to lose weight, a new study says that you should try eating a handful of walnuts. Walnuts are rich in omega-3 fatty acids and other substances, and in moderation have been linked to a reduced risk of obesity and diabetes. They can also help to reduce appetite. This study linking walnuts to weight loss, it was published in the journal Diabetes, Obesity, and Metabolism. Adding yet another reason for doctors to avoid the overuse of antibiotics, new research shows that a reduction in the variety of microbes in the gut interferes with the immune system's ability to fight off disease. Researchers have found that antibiotic use harms immune cells and makes them less effective in fighting infections. Antibiotics also weaken the intestinal barrier against invading bugs. The research connecting antibiotics to a weakened immune system, it was conducted at the University of Virginia School of Medicine. A new Australian study suggests that eating high amounts of artificial sweeteners affects how the body responds to sugar and hikes the risk of diabetes. Study authors say that this supports the concept that artificial sweeteners reduce the body's control of blood sugar levels. The study was unveiled at the European Association for the Study of Diabetes in Lisbon, Portugal. Now let's turn to my special guest, Dr. Beth Darnall. Dr. Darnall is a pain psychologist, clinical scientist, and clinical professor at Stanford University. As a principal investigator, her pain psychology research portfolio includes over $13 million in research awards from the National Institutes of Health and the Patient-Centered Outcomes Research Institute. Dr. Darnall, thanks so much for joining me today on Body Talk.
Oh, listen, thanks so much for inviting me on. I'm just thrilled. I think, this is a great, fresh audience and, venue to bring the message forward. So, my thanks to you.
In my work as a personal trainer, I come across people in pain on a regular basis, and I often find that although a person might come to me with, say a bad back, I usually find that the origin of that back pain is usually someplace else in the body. And I understand that you do something similar. When you see somebody with back pain or any other pain, you don't necessarily focus on the pain site as much as you focus on the brain.
It is such a good point, Bob, and I think, what's less appreciated among individuals who have pain, and even among providers and just the public, is that pain actually isn't situated where we feel it in the body. It's fundamentally a product of the nervous system. So that involves the brain and the spinal cord. And, this is really where I dwell as a clinician and a scientist because I'm a pain psychologist. So my work focuses on going straight to the central nervous system and figuring out how we can optimize patient outcomes and help reduce their pain by using various techniques that go straight to where pain is processed. Data that was provided by the Institute of Medicine and incorporated into the National Pain Strategy suggests that up to 1 in 3 Americans are living with ongoing pain of some type. So this is a massive problem for the U.S. population. It's the number one reason people visit their doctor for a medical complaint. It confers tremendous suffering in the lives of individuals, and it's the number one reason that people are on disability.
Now, how long does a person have to feel pain for it to be considered chronic?
So typically, the most common definition of chronic pain is pain that persists beyond the expected time of healing or longer than 3 months. Some definitions will use a 6-month definition for chronic pain, and the discrepancy between the 3 months and 6 months is really dependent upon how frequently a person experiences a pain. So 3 months if you're experiencing it on a daily basis that impacts, your functioning, and 6 months if it's more days than not.
And we have a worldwide audience here, and you mentioned how prevalent pain is here in the United States. Are the statistics pretty similar around the world?
Yeah, that's a great question, Bob. In fact, yes, pain is universal. It is really part of the human condition. And so in the United States, we don't have more pain than any other countries. It's really universal, these statistics, the incidence and prevalence. The difference is that we treat pain differently in the United States. We're much more likely to prescribe opioids to treat chronic pain in the United States than are most other countries, to the point that, the United States only has 5% of the world's population but consumes greater than 80% of the world's supply of morphine to treat chronic pain. So that just gives us, a little snapshot into the differences in how pain is treated around the world.
Now, I don't ever remember this being a real problem. I don't know if it wasn't talked about or if the treatments have changed. Why do you think we have so many more people in chronic pain today? Is it a fact of more statistical knowledge, or is it a reality due to the way we treat pain?
For one thing, people are living longer, much, much longer than they were before. And so you have people whose lives are extended by 10 or 15 years, and those later years, we're much more likely to have pain in those later years. So that's one piece of it. The other piece of it is the obesity epidemic. And so we're simply less active and in poorer health across those years. Those are two big pieces of the equation. And potentially the third piece is, we're just a little more focused on identifying and treating pain. Pain has always been there, but in earlier years, there was a much more stoic philosophy about pain than there is now. There's much more of a focus on people wanting relief and comfort. And that certainly is not a bad thing. I mean, that's really a great focus. But what we have to be sure that we're doing is that when people come for treatment for their pain, that we're steering them in the right direction towards those active self-management strategies where we're actually engaging patients in their care and in their rehabilitation, rather than setting them down a pathway of a passive approach on pharmaceuticals and procedures.
When we look at men and women and the perception of pain, do women suffer more than men, or men suffer more than women? Who has a higher tolerance?
Women suffer disproportionately from pain. So women are much more likely to acquire chronic pain, to have that pain be of a greater intensity, to have greater episodes, more frequent episodes of pain. So pain is just more painful for women, and it's much more likely to persist. And there are, physiological and psychological reasons for why women have more pain. It doesn't mean that pain isn't important in men. Clearly, this is a human problem that requires a lot of attention. But the way I language it to women is that because you're female, it's that much more important that we pay attention to these factors that you can control, because in some ways your biology is working against you.
You know, when you talked about that and the differences, it reminds me growing up when I'd be involved in some sporting activities, just messing around. When I hurt myself, the other men would say, you know, you got to brush it off. You got to be a man. You know, you can't feel the pain. And I think to some degree, men let that conditioning take hold.
Yes, yeah. So there are definitely some gender and sort of interpersonal factors that influence how we relate to pain and whether we receive treatment for it. So, you know, hands down, women are much more likely to seek medical treatment for their pain. And we actually see some differences in the patterns of the care that they receive simply based on sex and gender factors. So there's how we communicate our pain, behavior around pain, the treatment that we receive. But I also think on balance, it's important to recognize that, you know, for women, pain is of a greater intensity and it's more impactful. So they're much more likely to seek out treatment so that they can go forward productively with their lives and their goals.
So the brain's role is just so fascinating. I know that, you know, sometimes as I'm going through my day, there'll be times when I'll like smack into something really hard, and maybe for a split second I'll go, damn, that hurt, but I've got to go on to do something. I forget about it. I don't feel the pain, and then later that night I'm looking at this terrible bruise. It's almost like my brain numbed the pain.
Distraction is a beautiful thing. And, you know, in that example that you're describing, I mean, you really very quickly changed the channel in your brain. You steered it right away from pain. But imagine the individual who isn't able to do that, who is really sitting there focusing on that pain, intensely focusing on it, is distressed by it, continuing to magnify it, and is ruminating about the pain that they're feeling. That psychological response, that experience that one is having around their pain, actually amplifies pain in the nervous system. So I'm sort of describing something we call pain catastrophizing, where the brain is very focused on pain, magnifying the experience, ruminating, and also feelings of helplessness around pain. That is very clearly shown in brain imaging studies and MRI and fMRI studies. It is shown to amplify pain processing in the nervous system, and that links to the patient report of having greater pain. So this is the piece, you know, exactly what you're talking about is less appreciated by people, is that this is the opportunity we have to either dial down our pain experience or to unwittingly turn up the volume on our pain. We have a direct line into pain processing in our nervous system. And it's right here at this intersection of how we focus our brain in the context of pain. So this is really the realm of pain psychology. This is where my work is situated.
Let's look at how emotions affect pain. If I'm an angry person, is that going to amplify my pain response?
Yeah, absolutely. So certain emotions serve to amplify pain. Those emotions, feelings of sadness, depression, anxiety, anger. Those are just some of the emotional experiences. You know, we think of those emotions as being aversive or unpleasant. So pain is also aversive and unpleasant. And as it turns out, it's like they're all sort of processed in the same region of the brain. And when we are in a state of aversiveness or unpleasantness, regardless of whether that is physical or psychological, emotional, it's all the same. And so it all acts the same in the brain to amplify our experience around pain and vice versa. So that if I'm feeling angry, my pain is going to be experienced as more painful. And if I have a lot of pain, if I'm also having anger, my anger is going to be at a greater intensity as well. Think of it as having a bidirectional relationship between these aversive emotions and pain.
What about the other side? What if I fall madly in love with someone, and while I'm running to go into her arms, I trip and fall and hurt my knee. Is my infatuation with the person going to help my knee?
It is indeed. And so those positive emotions, and in fact, love is analgesic. And there's been some cool, really fun and cool studies done right here at Stanford University showing that when individuals, you don't even have to be in the presence of your loved one, that if you simply view an image, a photograph of an individual with whom you are intensely in love with, a romantic love, they show that during pain experiments, that an individual will experience analgesia just by seeing a photograph of their romantic partner. And so it does reduce pain intensity, and that correlates with dampened pain processing in the regions of the brain associated with pain.
Now, something else that fascinates me that I've heard you talk about in some of your lectures is how childhood trauma can actually affect pain later in life.
It is amazing how impactful early life experiences are in shaping the nervous system. And so if an individual has a traumatic experience as a child, it's as if it primes the nervous system for greater sensitivity to pain and future traumas, even into adulthood. Unequivocally, one of the biggest risk factors for persistence of pain is having post-traumatic stress disorder. And that, of course, is a psychological disorder, but it's acquired after the experience of trauma, so that someone may be involved in a car accident or some sort of even just psychological trauma, and the nervous system is placed on high alert, persistent high alert over time. And so, there is so much overlap between psychological trauma and the experience of pain in the moment, and then also risk for future pain. Some of it has to do with just how trauma impacts the nervous system, but people who experience trauma early in life, they may also be raised in environments where they don't necessarily learn the skills to best protect themselves from future pains, from future circumstances that may be harmful as well. So there's an intersection there.
So if someone like this has had childhood trauma, when you delve into that, can you actually help with present-day pain by helping them resolve some of that, or at least come to terms with some of that childhood trauma?
No question. Absolutely. Imagine an individual who had trauma as a child where maybe they were abused by a family member, and so they experienced the pain of physical abuse that they carried with them throughout their life as a psychological trauma. Later in life, they experience physical pain or physical trauma, let's say in a car accident, and they have ongoing neck pain that's from an injury sustained in a car accident. But the experience of that pain triggers psychological memories of early childhood abuse. And so what is encoded at a very young age is this linking between physical pain and trauma. And if we don't disentangle that, then we're constantly reenacting the early trauma whenever pain is felt. And that's what we need to focus on so that individuals can just go forward productively with less pain.
Thank you, Dr. Darnall, for joining me today on Body Talk. Finally, researchers have found a way to keep the brains of seniors younger and more vibrant. It seems that dance classes beat even traditional exercise when it comes to improving older adults' balance and in enhancing brain areas related to memory and learning. The study was conducted by the German Center for Neurodegenerative Diseases in Germany. Well, that's it for this edition of Body Talk. My producer is Katie Stell. The Body Talk theme song was composed by Rob Carlson and sung by Vicky Vox. If you'd like to stay up with medical studies on a daily basis, follow me on Twitter at BGPVideo. And if you have any questions or comments about this program, feel free to send me an email at lifestarmedia@gmail.com. Body Talk is a production of Lifestar Media.